Thank you very much. Good morning, everybody, and I'm sandwiched here between interesting talks on infection, millennium bugs by powerful speakers, Dr. Dilip Karnad, Madam Deshpande. There's going to be interesting talk after my talk on diabetes, various metabolic disorders. Mangesh is going to talk, Shashank is going to be here. And I'm here with a bold topic, COPD. COPD is ignored by all, by patients, by doctors alike. Allow me to spare next 15-20 minutes or so on telling you about newer concepts in the management of COPD. My sincere thanks to my teacher, late Professor Director Dr. K.C. Mohanty, who taught me respiratory medicine, organizers of today's program, mainly my friend Dr. Saraf, my friends Mangesh, Shashank, likely to be here, educational partners for today's program, my family, all my patients who gave me a chance to learn respiratory medicine, and of course, all of you for having spared your Sunday morning to be here. When I asked, Amit was very close friend. Amit was very close friend till yesterday. When he told me, Agam, you have to give a talk at Jupiter Hospital. I said, itne bade log idhar hai, Dr. Raju is here, why am I required? He said, you are a super specialist. In my joy knew no bounds. I said, super specialist mean too much. And I immediately made plans to travel till here. And then he sent me a WhatsApp message, what is super specialist? I'm sure a lot of you would have heard this. There's a cow that is kept in the exam, and there is an MBBS student. He says, cow. No second thought about it. There comes we, specialist. They said, this may be cow, or this may be a buffalo that is hypopigmented, having something like vitiligo, or maybe a goat which is suffering from obesity, or it may be an elephant which has got some genetic disorder, netrophed. And then comes super specialist like me. He says it's a four-legged white creature, maybe a mammal giving milk. What it is will be exactly known only after a set of investigations. So he said, there cannot be anybody but you to make a simple topic complicated, and here I present my views on COPD. I told him, yaar, aaj kyun? Sunday, family time. He said, no, today is very important day. Let's Google it, what's there in history for today. And I realized 27 February, on the same day, year 1700, Pest Island of New Britain was discovered. Same day, US Supreme Court upheld 19th Amendment that guaranteed women the right to vote. Same day, 1991, Kuwait was liberated by Gulf War allies. Same 2010, there was a major earthquake, 8.8 magnitude, in the South America, Chile, with more than 70% of country experiencing earthquake. I said, "ठीक है यार, अपने को क्या?" He said, "Not only that, you remember that Star Trek serial? Leonard Nimoy was the actor who died on the same day, 2015. Pakistani, apna recent Abhinav Vardhan's jet was shot down on the same day, 2019. 2021, third COVID-19 vaccine from Johnson & Johnson was approved by US. Not only that, in Indian history, if you see, Azad he shot himself as there was only one bullet left and he did not want to be captured by Britishers. And in 2002, that Godhra event happened in India. He said there cannot be any better day to talk about science because history is hardly history when you're walking through it. Who knows, in retrospect, this may also be recorded as one great CME which was held in Jupiter Hospital. I will be waiting for that. COVID is not over. Madam said, she gave overview about various diseases. 40 crore cases globally with 58 lakhs deaths, somewhere around 4.25 crore cases in India. We lost about 5 lakhs cases directly and maybe similar number indirectly with all those complications this patient had. And if I make very rough calculations, my limited calculation, it makes me think about one death every 2 minutes for the last 25 minutes. And Madam said there were about 1100 deaths in previous epidemics. We've lost about 2100 lives, medicos' life in this COVID era. That would mean 2 doctors lost their lives daily in this pandemic. But now life is getting back to normal, COVID is going down, and there cannot be any better time to talk about other diseases which would keep on bothering us. One such disease is COPD. One of the top 3 global causes of death. 90% of COPD occurs in middle and low income group. 5th leading cause of loss of disability adjusted life years. If I talk about our country, 2nd biggest cause of death in India today, with prevalence being 2.2 or 22% among men, 1.2 to 19% among women. Again, if I give you very rough calculations, common disease worldwide with significant morbidity and mortality kills 3 million people roughly, 3 million people every year, which would mean probably 3rd leading cause of death worldwide, almost 5 deaths occurring every minute. So by the time probably our discussion is over, we would have lost so many patients because of COVID. An acute exacerbation would cause problems, would add to their morbidity. Causes, we all know. There is 2.5 billion people rely on biomass, and US estimates that firewood smoke contributes to over 20,000 tons of fire particles. And trust me, they consume only 1/10 of fuel wood. So we probably would be having at least 5 or 6 times the problem. Indian chula, and there is a new trend coming. If you go to 5-star hospital, there is now trend of making those naans and parathas on that chula. So that thing is coming back, probably would add to further problems of air pollution. Smoking, village, women smoking, all that is increasing. Indoor pollution contributes significantly to COPD development. And recent survey, 9 Asia Pacific countries, the prevalence of COPD was estimated very high, 6.2%. With that, let me talk about definition of COPD. When I was a student, Dr. Raju would remember, sir, when we were there, or when you were there, sir, quite senior to me, there was a unspoken dictum. Madam also would be aware not to put COPD patients on ventilator. We were told COPD patient yani ventilator dependent, marega bhi nahi, jayega bhi nahi, you can't put any patients on ventilator then, and you will be stuck with this patient. But then scenario is changing. We have now realized COPD is not all that bad disease. We can help our patients. The current understanding of COPD is it's chronic obstructive pulmonary disease, common, preventable and treatable disease, which is characterized by persistent respiratory symptoms and airflow limitation, which is due to airway and or alveolar abnormalities, usually caused by significant exposure to particles and gases. And the previous terms which were removed out of it was progressive, enhanced inflammatory response, exacerbations, comorbidities, etc., giving it fairly positive outlook, because previous definitions would give a very negative outlook to this disease. Diagnosis in presence of risk factors. So whenever you have tobacco consumption, occupation, indoor and outdoor pollutions contributing in a particular case, and case suffering from shortness of breath, chronic cough, sputum production, you would subject them to spirometry. And hence, for diagnosis of COPD, spirometry is must. You cannot make a clinical diagnosis of COPD. You may suspect COPD clinically, but you will have to do a spirometry to establish diagnosis. And once you do spirometry, their post-bronchodilatory lung values, that is FEV1 by FVC, once it is less than 70%, that confirms obstructive airway disease. If you do their pre and post, and if there is reversibility, more than 12% improvement in FEV1 or more than 200 cc improvement in FEV1, that is a reversible airway obstruction, which is a hallmark for asthma. But whenever it is irreversible, that means whenever your post-bronchodilatory FEV1 by FVC is less than 70%, that confirms diagnosis of COPD. This is how we decide the treatment plan. Earlier, we were taking more variables into consideration. We were taking 3 variables into consideration. We were looking at severity of exacerbation, we were looking at symptom score, and we were looking at risk of future exacerbation into consideration before you plan a treatment. But the recent guideline tells you this is how you would make plan for treatment. First, confirm diagnosis. That means subject all these patients to spirometry for sure. Once you have that post-bronchodilatory FEV1 by FVC of less than 70%, which confirms your obstructive airway disease, irreversible, look at FEV1 values. FEV1 values, depending on the predicted level, that is more than 80% or less than 30%, it is divided into different grades, 1, 2, 3, 4, that is mild, moderate, severe or very severe. But then when you're deciding treatment, leave both these aside. You put only two variables. One is the symptom score, that is, you remember second MBBS, MRC grading, patients breathless at rest, which is severe most, and patient breathless only on unaccustomed activities is a higher grade. This is, you look into that, take that into consideration and divide MRC of 0 to 1 or more than 2 into two parts and look at the risk of future exacerbation. The only predictor for judging risk of future exacerbation is the number of exacerbation patient had in previous years. So if your patient had no exacerbation or mild exacerbation, it is in the category A and B. You draw a horizontal line. Any patient has got 2 exacerbation or severe exacerbation, any exacerbation that required hospitalization, you put them in the category C and D. And that's how you get a matrix with A, B, C, D. So your A patient will be less symptomatic and at a less risk of getting exacerbation, and your D category patient will be more symptomatic patient and at a more risk of getting exacerbation. Once you do this, your treatment plan is very simple. Your treatment plan, according to the group there, A, B, C, and D, is this. You would put them on a bronchodilator. So when patient does not have high risk of exacerbation, where patient is less symptomatic, you have done their spirometry, FEV1 by FVC is 70%, this patient can be put on bronchodilator. You will put them on inhaled bronchodilator. That means you have a choice of putting them on beta agonist, any of your falmetrol, salmetrol, indicatrol, etc. You can put them on that. Or you can put them on anticholinergic drug. We have atropine derivatives, so you can put on any anticholinergic drug. Category B would be patients who are more symptomatic but are at a less risk of getting exacerbation. And here you would put them on a combination therapy. You can put them on LABA or antimuscarinic drug, that is anticholinergic drug, individually, or you may put them on a combination depending on their symptoms or symptomatic relief. Category C patients are less symptomatic, but they are at a higher risk of getting exacerbation because they had exacerbation in previous year or they required hospitalization in previous year. And here you will put them on combination therapy to begin with, that is, you will put them on LABA and LAMA combination. And if this patient is asthma COPD overlap, or if patient has multiple exacerbation, or if this patient has eosinophilia, you will add inhaled corticosteroids here. And the last category would be, you will put them on LABA and LAMA to begin with for sure, and depending on their phenotypes, depending on whether it is more of chronic bronchitis type, more of obesity type, you would think about adding newer molecule like roflumilast. If patient is a previous smoker, or if patient is a neutrophilic predominant or neutrophilic variant kind of COPD, you will put this patient on a macrolide therapy. That is very simple treatment chart. This is for initiation of treatment. So you would initiate patients on this therapy, and when they come for follow-up, you will look at their symptoms or their improvement. So you have initiation, which is based on this ABCD assessment, based on the risk of exacerbation and their symptom score. And when they come for follow-up, you will look at whether this patient has got more dyspnea or this patient has got more exacerbation. If patient is stable, you will continue the same class treatment. There is no step down as you have in asthma, because COPD is a progressive disease. COPD is not a reversible disease. There are only few situations when you will reduce inhaled corticosteroids. I will come to that. But in most of the situations, this patient will be on double drug, that is LABA and LAMA combination. Suppose if this patient comes to you on follow-up and he's got more dyspnea or he's got more exacerbation, this is the chart for that. If your treatment to initial treatment is good, you will continue that, make no changes in that. If it is not good, you will look at the exacerbating factors. You may have missed associated disease, you may have missed allergic rhinitis there, you may have missed associated cardiac disease there. Very often you would have missed associated sleep apnea, GERD and pulmonary hypertension. This may be contributing to their symptoms. Once you look that, you treat that, and then still patient complains of more of dyspnea or more of exacerbation. Now you forget your ABCD. Patient has come for follow-up, whatever treatment is going on, you would decide the further line of treatment based on this. So patient is on LABA and LAMA combination, you will probably consider switching them from one combination to the other combination. You would think of shifting them from one inhaler device to the other device because patient may not be compliant enough, may not be comfortable using those devices. And if patient has got more eosinophils or if patient has got asthma phenotype there, you would add inhaled corticosteroid there. If patient has got more exacerbation on that arm, you will put them on LABA-LAMA combination, you will add inhaled corticosteroids, and depending on the phenotype, if it is obesity, if it is bronchitis phenotype requiring hospitalizations, etc., you may think of roflumilast because that would reduce number of hospitalization in time to come, or you may put them on azithromycin if patient is a poor smoker or is got neutrophilic predominant. So this is, you will begin categorizing treatment, initiate first line treatment and follow it up depending on patient's response to treatment, either continue same treatment or if patient is more dyspneic, follow this part, if it's got exacerbation, follow that path. Blood eosinophil count would decide about inhaled corticosteroid. So if you have eosinophilic predominant, that means if you have facilities to do sputum eosinophils, which most labs do not have, you rely on peripheral eosinophilia. If patient has got more exacerbation, if patient has got associated allergic rhinitis, if there is a family of asthma, allergy, and now patient is smoker, develops fixed obstruction, these are the patients who are put in the category of asthma COPD overlap, and you will put them on treatment accordingly. For the first time, last 2 years, Gold gave you de-escalation of treatment. It was always given to step up treatment because patients would continue to deteriorate, patient's lung function would continue to deteriorate, it's a progressive disease. But in situations, you can consider de-escalation of inhaled corticosteroids. We have realized that inhaled corticosteroid may have their own side effects in cases of COPD. In asthma, there is no go back. All asthmatics have to be on inhaled steroid. But in COPD patients, you can de-escalate because it may not be required. It may put you at a higher risk of infection. There are cases of pneumonia which are reported with inhaled corticosteroids. And hence, if your patient is stable, if your D category patient is stable, as exacerbation is taken care of over next 3 to 6 months time, you can safely de-escalate, remove that inhaled corticosteroids and continue them only on dual bronchodilator, that is LABA and LAMA combination. So this is the place of inhaled corticosteroids in today's time. Only group C, where you have more of asthma phenotype, or you have eosinophils, or you have asthma COPD overlap. And in last group D category, where patients suffer more exacerbation, require more hospitalization, in this category of patient you will give inhaled corticosteroid. Otherwise, inhaled corticosteroids have got no role in the management of COPD. Most of your stable COPD patient would require only dual bronchodilator, LABA and LAMA combination, and no inhaled corticosteroid. The new changes which are there in the Gold 2021 and 2022 are certain informations about exposure to environmental particles, alpha-1 antitrypsin deficiency. There are some updates on e-cigarettes, vaccination, rehabilitation, self-management, ventilation and home ventilation strategies. There are newer formulations which are added. Role of triple drug combinations, mucolytic and antioxidant is spoken about. There are new sections on psychological aspects, lung cancer management, near-death management. There are chapters on COVID-19 and COPD management, and there are non-pharmacological treatment are also equally important. All those who are interested in this could refer to literature. I would end my presentation by saying that it is not as bad disease as we were looking at COPD about 2 decades earlier. We can give good symptomatic relief and prevent or reduce the disease progression in a lot of our COPD patients by timely diagnosis, and hence spirometry is must. Please do ask for spirometry whenever you have patients who are exposed to indoor or outdoor air pollution and who are exposed to tobacco, when they have cough, sputum production, these are the patients, and of course shortness of breath, these are the patients, ask for spirometry, and once spirometry confirms FEV1 by FVC of 0.70 post bronchodilator, these are the patients to be given advice about lifestyle modification and initiation of treatment. I would conclude by a famous quote, which is my quote, not so famous, but still, how something appears is always a matter of perspective. Everything we hear is an opinion, not a fact. Everything we see is perspective, not the truth. Thank you very much for your patient hearing.